Okay, so in these next 20 minutes, I'm going to talk to you about lung injury. And it is a fact that as radiologists, we do contribute to the management of patients with our imaging tests who have lung injury. With the skill of the anaesthetists and the clinicians who look after these patients, an increasing number of patients are certainly surviving this acute phase of abnormality. The plain chest X-ray, as I think we will all understand, is a workhorse investigation. But CT and other tests, at least in the initial phases, simply provide a supportive role. But work and the literature tells us that there are considerable insights that we've gained from CT imaging, as I hope to show you in these next 20 minutes. So I have three major aims. I'll be considering briefly some of the basic radiological aspects of imaging of critically ill patients. We'll review some of the specific features of imaging in patients who do have lung injury and acute respiratory distress syndrome. And then, as I've already hinted, we will discuss some of the values of and the pathological insights that we've gained from CT and perhaps some other tests in lung injury and in ARDS. How am I going to achieve these aims? Well, I have three principal questions that I'm going to ask. First of all, what are the principal roles of these various imaging tests that we have at our disposal when managing these patients? Secondly, does CT add anything? Should we really be performing CT? And that leads on then to the third question, is there any prognostic information from imaging that we can provide to patients who are critically ill, and particularly the physicians who care for these patients? What is or are the principal roles of chest X-ray or CT and the other imaging tests in the management of patients who are critically ill? Well, as radiologists, we are nothing if not diagnosticians. So diagnosis may be one of the roles of imaging tests. Certainly, on a day-to-day basis, we use imaging tests to monitor progress and indeed resolution of changes in patients who have lung injury. And finally, we continue to provide a useful role in the detection of clinically unsuspected complications in these patients. So let's think about the diagnosis of lung injury. Do we really contribute? Well, certainly we are part of there in terms of the diagnostic criteria, but actually the diagnosis of lung injury and ARDS is made, as I'm sure you know already, on physiological criteria. And most importantly, it's the ratio of the arterial oxygenation to the fraction of inspired oxygen. When that ratio is less than 300 millimeters of mercury, patients are characterized as having acute lung injury. When that ratio is even lower, then patients have full-blown ARDS. In all other respects, the criteria are similar, so patients have an acute origin. Chest radiography does play a role in that because it shows bilateral diffuse infiltrates, and the clinicians needed to have excluded a cardiac cause, so the wedge pressure needs to be less than 18. But the key feature is that the physiological criteria need to be met when making a diagnosis of ARDS. Radiology provides a supporting role in the diagnosis. Now, there is a relatively stereotypical pattern of histopathological changes, and it's worth just revising these quickly, even though there is considerable overlap. However, initially, there is an exudative phase when the interstitium becomes engorged. Sure enough, after that, then there is flooding of the interstitium and then opening up of the barrier between the alveolar cells and flooding into the air spaces, and eventually it then leads to a phase of healing where fibrosis is then laid down. And the radiology tends to mirror, to a greater or lesser extent, that kind of sequence of pathological events that we know. So initially, in the exudative phase, the very early phase, the chest X-ray may be normal, but eventually we will see areas of ground glass opacification, followed by more dense parenchymal opacification, and finally signs that the lung is then healing, and we will see signs of fibrosis. And I will come to that later on in this talk. Now, there are causes of ARDS, which I'm sure we all know, but it is worth thinking about the causes of ARDS under two main categories, the pulmonary and the extrapulmonary. What do we mean by extrapulmonary? Well, ARDS doesn't always start off with a problem inside the lung. So systemic sepsis, when it's non-pulmonary, or major trauma, again, not involving the lung, can eventually lead to ARDS or lung injury in the lungs. Of course, there are problems starting inside the lungs. So massive aspiration, infection, whether that be bacterial, viral, or PCP, can all also lead to lung injury. Now, this is quite useful when we come to consider the CT changes, because shown here on your left and on your right are the two caricatures of ARDS that we've come to recognize. On the image on your right, you will see that there is a gradient from front to back, and I'm going to explain that in a little while. However, if you read through the literature on lung injury, you will realize that this pattern has come to be regarded as the typical pattern of ARDS, and by contrast, this pattern has come to be known as the atypical pattern of ARDS. Now, it just so happens that if you do the analyses of these patterns and you put them together with the potential causes of ARDS, i.e. the pulmonary or the extrapulmonary, then it so happens that the typical pattern tends to go with extrapulmonary causes. In other words, this very symmetrical distribution with this gradient from front to back, whereas when it looks more patchy, it tends to be that there was a pulmonary cause. So, for example, massive aspiration, or that this ARDS started off as an infection inside the lung itself. Now, I will come back to this gradient from front to back because it relates to the SAMS question that I have posed. Sometimes in pulmonary ARDS, and this may be related to the fact that the dynamics of the lung in pulmonary causes of ARDS tend to be much stiffer, and so patients who do have pulmonary ARDS also tend to have much more in the way of cysts, thought to be a consequence of the higher pressures needed to ventilate these patients. Occasionally, ARDS will be wholly unilateral. Now, we tend to think of ARDS as a bilateral disease. However, in patients who've had a pneumonectomy or surgery on one lung, where that lung has then been isolated during the surgery, then ARDS tends to embed itself in the opposite lung. So just because you have unilateral abnormality does not discount the diagnosis of acute lung injury or ARDS. What else do we do with imaging? Well, we can certainly monitor progress. I'm not going to labor this point. We do this day in, day out as radiologists. And of course, we can also detect complications. Again, I'm only just going to show you a few slides. And clinicians used to be able to hide behind the procedures they used to undertake. But now, with the quality of imaging that we produce, we can tell them exactly where they have and where they shouldn't have placed their chest drains. So does CT add anything to our analysis? Well, CT is nothing if not a big density meter. CT, at the end of the day, tells us about differences in physical density, plain and simple. And the density of the lung, as we all know, is essentially determined by the relative amount of air inside the lung. Air on CT, as we know, is black. And so any changes in the amount of air in the lung will change the density of the lung. And that, in an essence, is CT of the lung. I know I'm simplifying it, but this is important. So when you get infiltration in the lung, and it doesn't matter what that infiltration is, we get changes in the density of the lung, and the density of that lung will increase. Well, we can use CT to analyze the lung in this way. So depending on the density of the lung, we can categorize lung as being either normally aerated, through to poorly aerated, right through to non-aerated lung. And here you can again see this gradient of density from the front to the back. And in fact, this type of analyses have been done by Professor Gattinoni and colleagues, and he really is a pioneer in this field and has shown that you can compare ARDS lung with normal lung being black, full of air, is skewed typically to the right if you do a density analysis, whereas ARDS lung appears to be skewed to the right-hand side. And these type of analyses actually showed us that the low compliance that we actually associated with ARDS is essentially related to the amount of normally aerated lung. Why is that important? Well, it's important because this has changed our thinking of the way that the ARDS lung behaves. ARDS lung essentially is like baby lung. So the amount of normal air you have determines how low your compliance is. Gattinoni and colleagues have done very sophisticated analyses because they've used imaging to predict which patients may and which patients may not respond to PEEP. And so if you can see here, this is taken from their paper published in the New England Journal 5 years ago. you can see that by applying 5 centimeters of PEEP in this by going from 5 centimeters of PEEP pressure up to 45 centimeters, actually there was very little morphological difference. By contrast, in another patient, you can see that the same increase in PEEP pressure actually makes a significant difference morphologically. Not only that, visually, you can analyze these data and you can categorize patients into those who may or who may not respond to PEEP. So this is a very powerful way of using CT in these patients who have lung injury. Now, I've talked about this gradient from front to back. Now, you might imagine that because this lung is wet, we're simply looking at the gravitational effect of the effect of gravity on the distribution of edema. And that makes sense, it's intuitive. However, again, CT analyses have shown that in fact the wet lung in ARDS simply behaves like a sponge. And so the pressure as we go down from the ventral lung down to the dorsal lung increases progressively. And so the lung, behaving like a sponge, actually pushes down on these lung units, and these lung units, rather than representing more edema, simply represent areas of atelectatic lung. And we see this every single day on CT, because we know that when we have patients in the supine position, we will get areas of increased density. These are also areas of atelectatic lung. It just so happens that in ARDS, this is an exaggerated phenomenon. And the heart might also contribute to this. So not only is the lung behaving like a sponge because it is wet, but also the heart becomes much heavier. And that's been shown in this very elegant study published in the Blue Journal a few years ago, showing that not only does the cardiac mass increase, but cardiac volume increases in patients with ARDS. And the heart itself bears down on the lung. So the lung is behaving like a sponge initially, and has a tendency to collapse those dependent lung units, and the heart also then contributes to that effect. Now that collapse of lungs, certainly in the acute phase, is accountable or accounts for the hypoxia that these patients have. But in a perverse kind of way, these dependent areas of atelectatic lung actually have a potentially beneficial effect, because these patients are ventilated with relatively high pressures sometimes. And because these units of lung are collapsed, it turns out that they may have a protective effect against barotrauma. And this is a paired examination in the same patient, taken 6 to 7 months after recovery, and it shows that all the dependent areas which were atelectatic in the acute phase appear relatively normal, but there is now a reticular pattern in the non-dependent lung. And you can see this in these 3 different patients showing this exact same phenomenon. So we've got reticulation, areas of ground glass opacification, also some tractional dilatation of airways, indicating that this may be fibrosis that is being laid down, and it's in the non-dependent lung because this is unprotected lung during the acute phase. And fibrosis is part and parcel of ARDS. And the ventilation may certainly contribute. So if you look at the extent of this reticular pattern and you correlate it with the duration of different forms of ventilation, then there is certainly a strong correlation. And indeed, certain forms of ventilation, so-called pressure-controlled inverse ratio ventilation, have a more significant effect than other forms of ventilation. So as I've already said, fibrosis certainly is part and parcel of the model of lung injury. And one of the best models of lung injury is actually diffuse alveolar damage, or AIP, acute interstitial pneumonia. And this are images taken from this paper, again published in the New England Journal by Ishikawa and colleagues, where they looked at CT features of AIP and correlated those with histopathological findings. And you can see here in this image that you have widespread ground glass opacification. Within the areas of ground glass opacification, there are some dilated airways, and that is important. And various studies have shown that whatever markers you use, there is certainly clear evidence of fibrosis in patients who do have lung injury. So this is a very intensely fibrotic or potentially fibrotic lung process. I said I would just consider very briefly some of the prognostic information that we might be able to give from CT images. So is there anything we can tell the clinicians about their patients from our imaging tests? Well, again, if we use this model of acute lung injury and we quantify the various patterns that we see, so the ground glass opacification, the areas of consolidation, and also these areas of dilatation of the airways, which we believe to be a marker of the fibrosis, then there certainly is some prognostic data in there. Because if you look at all of these signs, you will find that there are independent relationships between this sign of tractional dilatation of airways and markers of outcome. So there is prognostic signal in the images that we look at in these patients.